And here is your question. Right, so if you have read and understood, considering it surgical pathology station, kindly tell me what are your differential diagnoses after reading the stem?
Basal cell carcinoma. Then others are squamous cell carcinoma and malignant melanoma.
Okay. Can you tell me how would you confirm your diagnosis? What investigations would you ask for?
To confirm my diagnosis, I want to take a biopsy.
You want to get the biopsy done? Anything else? I'm sorry, I can't hear you. Can you please tell me if you'll ask for, yes.
I also want to do some radiological investigations before the biopsy, CT or MRI of the cranial of the brain of the head, so as to know to delineate and stage the tumor. Then I also want to do some blood tests for the patient, and then biopsy for him.
Okay, can you
or do an FNAC?
Can you please tell me once you have done the, yes, if you, can you hear me? Can you please tell me if you'll do the biopsy, considering your differential diagnosis, what are the findings that you expect to find or see on the report?
Yes. Present, the pictures I want to see on the report says I want to see the tumor involving the basal and the basement membrane of the skin, and that the tumor is arising from the skin. And then I will be interested in the number of mitotic figure, and if there's any is locally infiltrative and the underlying tissue, the extent of the tumor infiltration.
Okay, so you're considering the depth of invasion, the margins, and the ulceration and pellucidations. Okay, yes. If you consider all your differential diagnoses, then can you tell me what is the natural history of basal cell carcinoma? How it takes place?
Basal cell carcinoma is an indolent tumor.
Yes.
But is locally aggressive and rarely metastasized.
Yes. And
so that's the
it originates from
and it can,
yes.
It originates from the deeper layer of the skin.
Okay, good. How would you differentiate basal cell carcinoma from squamous cell carcinoma?
To differentiate the basal cell carcinoma from squamous cell carcinoma depends on where the tumor is arising, and then immunohistochemistry will also help.
And
the layer of the skin where the tumor is arising from, the histology, and then immunohistochemistry.
Yes, and
then
more.
The presence.
You have to tell me 3 to 4 reasons quickly.
The extent of the tumor, also the nature of the tumor. In squamous cell carcinoma, it will have inverted edges, while the basal cell carcinoma will have rolling edges, and then the basal cell carcinoma will rarely metastasize, while squamous cell carcinoma can metastasize.
Okay.
Then the squamous cell carcinoma usually occur in other parts of the body, while basal cell carcinoma usually occur in the neck and head region.
Okay. Can you please tell me what are the 5 major steps which are involved in the metastasis of a skin carcinoma?
Okay, there is separation of the tumor cells from the main malignant cells. Then the tumor cells get infiltrate locally.
Infiltration.
The tumor cells infiltrate locally.
Yes.
Then after infiltrating locally, it separates from the main tumor. Then
yes.
It gets permeated through the blood vessels wall and then enter into the blood vessel. Then supplies and survives in the blood vessel. Then it gets embedded in the capillary beds of the target and organs. Then from the after getting embedded in those capillary beds, then it survive and continue to grow in those target organs to form a metastasis.
All right. Okay. Once you've done biopsy, you got confirmed that it is basal cell carcinoma. Then what is the treatment that can be offered to the patient?
The treatment options include excision of the tumor, and then primary closure or use of skin graft or flap to cover the residual wound.
Okay. And
one can also use MUMS micrographic surgery. Then one can also use of chemotherapy like topical fluorouracil can also be used. And then there is also use of curettage and electrodesiccation. And then use of cryotherapy can also be done.
And radiotherapy?
Yes, and radiotherapy.
Right. Once you are excising a basal cell tumor, okay, can I please, if you can help me to read this, what can you see?
Okay, there is a popular lesion that has a surrounding telangiectatic area surrounding tumor. The tumor has a roll in edges with a central ulcer.
How big is it? What is the size approximately?
The size is about 1.2 by 1.2 centimeter.
And the shape, how would you describe it? Is it round? Is it oval? Is it elliptical? Is it how would you explain?
The shape is that regular shape.
Okay. All right. Considering that patient has this lesion and it's basal cell carcinoma, what margins would you keep in your mind when you are excising this lesion?
Yes, I will give a 2 centimeter margin since the tumor is about 1.2 cm.
Why 2 centimeter, 2 millimeter?
2 centimeter, man, 2 centimeter.
Yes, okay. Sorry, I thought you were saying 2 millimeter and I was wondering. Okay, once you're considering the, you're considering the margins. So what else would you consider?
I also consider the depth of the
invasion. Yes, very good. All right. Okay. Once you have excised the lesion and the patient comes back to you after 6 weeks and the lesion is not healing, what would you suspect?
I would suspect wound infection.
Okay. What would you do?
Then I want to do a wound swab for microscopic sensitivity.
What is the most common organism that causes infection post-excision?
Staphylococcus aureus.
Okay, very good. Right. Cell is gone, but yes. Right. Okay. Can you please quickly tell me what is the difference between Breslow thickness and Clark's level? When are these are important, or for which scenarios would you consider them more? For malignant melanoma? It was also one of your differentials, or wasn't it? Okay, thanks.